Hi everybody, good evening, and we meet again for a session on exercise and congenital heart disease. I'll aim to give you an overview of the current status and recommendations for physical activity and exercise in patients with congenital heart disease. Just get this to move. Fantastic. So one of the issues with children with congenital heart disease is that they have restricted or decreased levels of physical activity when compared to normal children. Now, there are various factors that are responsible for this reduced physical activity, but they are at a higher risk of obesity as a consequence of having reduced physical activity, and as a result, they are at a higher risk of adverse cardiovascular events, in the long term. It has been noted in several studies that not only do they have decreased levels of physical activity, but they overestimate their activity levels. They also don't have a very clear idea as to what they can and can't do. So all of these issues are issues that, as clinicians, that we need to address when we consult with our patients in our clinics. In addition to, looking at their clinical condition and giving them medications, this sort of physical activity advice, in fact, might be much more important in the longer term. Children with congenital heart disease also have delayed motor development when you compare them with the normal population. So it is important to pay particular attention to various motor skills during their development to make sure that they receive, sort of input in terms of physiotherapy or some sort of therapy to help them to progress with their motor skills if we find them to be lagging behind. Now, if we look at why children with congenital heart disease have restricted physical activity, can you come up with some answers as to why specifically children with congenital heart disease may have restricted physical activity? So I want some participation here. Any ideas? So why do you think a child with CHD could probably be doing less? Hypoxia, okay. What are the factors? Fine. Correct. So conservative parents, parents tend to be quite protective of their children. So even if their child has only a minor heart problem, the whole, idea of having a heart problem scares parents, and they tend to sort of mollycoddle the child and be overprotective of the child and not allow them to do, as up to their potential. Inability to increase cardiac output. So by that we mean, maybe an inability to increase the heart rate if there is some sort of, sinus node dysfunction or some rhythm issue, and also inability to increase the stroke volume, which could be a functional issue. So of course you have all the various structural reasons why children may not be able to perform, children with CHD may not be able to perform as well as normal children. But in addition to that, and this is probably the most important point I want to focus on in my talk today, that often, it is not necessarily the hemodynamic issues or the structural issues, but it is more the the parental issues, the physician issues, etc. So, like we discussed, physical activity restriction can be either due to the practitioner, i.e., the physician who's looking after the patient may not have adequate knowledge. He may be out of date. He may not be the right person to actually advise the child. But as you know, in India, access to a qualified pediatric or congenital cardiologist is limited, and many of our patients live in areas where they have only a basic sort of family practitioner to consult. Now, this person obviously may hardly know about the heart condition, leave alone be in a position to give them advice about exercise. and of course fear of medical liability. I mean, this is perhaps more abroad than in India, but the doctor might say, to be on the safer side, I'll tell the child not to do these things, but that's really not the right approach. Then of course parental we talked about, and then self-imposed. Now these children may have scars on their body which they may not want to reveal to their peer group. Also they know that they perform less well than their peers. So exercise performance is very linked with doing the exercise. So if you and I started to run today and we haven't been running up till now, just purely our fitness, because we have poor fitness, we will not be able to exercise well. But as we work on it, this exercise capacity or ability to exercise will improve. But in the initial stages, this might sort of discourage the child or the young adult with congenital heart disease from pursuing exercise. So these are the various factors that lead to physical activity restriction in our patients. So we go on to the issue of obesity. Okay, now this is data from the US, and it was published fairly recently. It was noted that nearly 30% of the overall population, children, are obese. Okay, they looked also at not just the overall population, they also looked at children, different subgroups of children, depending on racial and ethnic distribution, depending on whether they had heart disease or not. So they were able to get some useful information from sort of subgroup analysis of this data. They found that overall, children with heart disease had more or less the same percentage or level of obesity as the overall population. So nearly 30% was the overall the incidence of obesity in the overall population, and children with heart disease, I think the percentage was 26%. But the interesting thing was when they looked at the subdivisions amongst these children, they found that children with minor heart disease, this is the group which says heart disease, no intervention, and also the children with electrical problems, perhaps some tachycardia, some palpitations, so often, these are minor sort of electrophysiological problems. These were the kids who were actually more obese than the average population. So these were probably children who should not be restricted and who could probably have the same level of physical activity that a normal child could have. But because they have the label of the heart disease, there is this fear of exercise. Like patients with single ventricle physiology, Fontan, etc., they often suffer from failure to thrive. There is a degree of failure to thrive in these patients. Therefore, they were not actually, the percentage of obesity in this group was actually less than average. But it was those children with mild abnormalities who could probably exercise as much as overall general population. These were the ones who were more obese. So what is the problem with obesity in childhood? I mean, what's wrong with a chubby child? Looks quite cute, and they'd grow out of it, wouldn't they? But that's not true. Okay, so childhood obesity is linked closely with adult obesity, and it has adverse cardiovascular effects. Now, if you look at what are the specific risks for obesity in congenital heart disease patients, we already know that they have restricted physical activity due to a variety of hemodynamic and social reasons. The other issue is really high calorie intake. Now, prior to surgery in a child with, say, a VSD or a heart condition, we keep emphasizing to the parents that weight is very important, that the child should gain weight in order to be of lower risk for surgery. So this gets really embedded in the parents' mind. But what we fail to tell them is once the condition has been corrected, as the child grows and reaches sort of normal weight and height for his age, then they should go off this overfeeding policy and make sure that the child actually doesn't get overweight or obese. So I think it's important for us. I mean, it's a bit unfair to expect the parents to appreciate this themselves, I think it is important for us as clinicians, once the lesion has been corrected, to then, and we notice that the child is now gaining weight and perhaps, gaining too much weight, we should make it a point to then start counseling about lifestyle issues, about dietary issues, activity issues, etc. So these are the risk factors, specific risk factors for obesity in children with congenital heart disease. Now, obviously, apart from this, there are all the general risk factors, i.e. the sort of lifestyle that children now lead, where they have very little outdoor activity, a lot of sedentary activities. Now, the recommendation, daily recommendation for sedentary activities like watching TV or playing on the computer should be less than 2 hours for an individual. But I'm sure that the majority of our children are spending a lot of time in front of the computers and televisions, and having excessive time just doing nothing. So going on to the question of what is the impact of obesity on cardiovascular health in these patients. Like I said before, childhood obesity is not a benign phenomenon. It is closely linked with adult obesity. Also, it has been noted that these obese children, are also hypertensive. And you all know that hypertension is a risk factor for adverse cardiovascular outcomes in adult life. Studies have been done which have looked at certain markers of coronary artery disease, for example, carotid intimal thickness or peripheral vascular abnormalities like the stiffness of peripheral vascular vessels, peripheral vasculature, and they have noticed that there have been abnormalities in these obese children as compared to normal children. So a fat child or an overweight or obese child is not a laughing matter. It is something that should be taken seriously. If we think about coronary artery disease and congenital heart disease, there are specific high-risk populations. I'm sure you all are aware of these subgroups, but I will just quickly whiz through them. These are specific high-risk populations because they have a specific problem with the coronary arteries. Either it's an intrinsic disease like the Kawasaki disease, or they have had surgeries that have involved coronary translocation. So these patients, for example, the arterial switch or Ross procedure of following anomalous left coronary artery to pulmonary artery repair, these patients are at specific risk of coronary artery abnormalities, and they have to be monitored during their childhood and through adult life carefully. Now, this is a paper that was published in 2000 in Heart, and I think there are a couple of points I'd like to highlight from this paper. This looked at patients in an adult congenital heart disease clinic, gave them a questionnaire to assess, their knowledge of how much activity they were allowed to do, to assess how much activity they actually were doing, to assess how much information about exercise and physical activity they had received. And it was quite shocking to know that more than 70% of these patients, the topic of exercise or physical activity had not been raised by any of the caring clinicians. Only 30% of these patients actually asked for the information themselves as well. So, this aspect of health, which is exercise and physical activity, should be mandatorily discussed at every consultation, once the child has gone beyond a certain age. So this was quite, a poor reflection of the care that these adult congenital patients were receiving. Now, if you look at the graph on the right side, okay, you have the recommended activity levels by the American Heart Association. This is in the these are the empty boxes, and the dark columns are the patient's current activity. So when they looked at this whole group of patients, the majority of the patients actually should have fallen within the American Heart Association categories 1 and 2. Okay, if you look at 1 and 2, it means either no limitation, meaning they can do anything they want, or moderate exercise, which includes running, tennis, football, etc. So a fair amount of activity really. So about 75% of this population should have been in these categories 1 and 2. But if you actually look at how many of these patients were in these categories, these are the dark columns, it's only half of the 76%. So only about 38% were actually performing at the levels that they were expected to perform at. Okay, majority of them were actually performing well under or well below the recommended activity level for their heart condition and clinical status. So often I think with congenital heart disease patients, they tend to do, except for specific subgroups like high risk subgroups, majority of them tend to do less than they could potentially do. And I think this whole stigma of having a heart problem is one of the reasons why this happens. So if you look at before recommending exercise, or before making recommendations on physical activity to these patients, what are the possible ways to assess the activity level of the patient? So how can we assess the exercise capacity of the patient? Now I'm sure you're all familiar with these techniques, and they're quite commonly used techniques, in our field. But I'd just like to mention them. So all of us know about the 6-minute walk test. Basically, this is just an assessment of the distance that a patient can walk in 6 minutes. It is often done down the corridor, so we often find a nurse walking a patient up and down. Usually, the length of the of the track should be at least 30 meters, and this test is particularly useful in severely limited patients. So if a patient is doing over 400 meters in the 6-minute walk test, the test becomes less sensitive. So it's not particularly useful in patients with good exercise capacity. Or moderate exercise capacity. It is particularly useful in severely limited patients. For example, if you have a severely limited Eisenmenger patient who's not able to manage much and is deeply sinus, maybe in that sort of patient, the 6-minute walk test might be useful. But if they have moderate exercise capacity, the utility of the test gets diminished. Of course, the 6-minute walk test is influenced by things like physical disability. So if the patient has any gait issues or any balance issues because they have to turn around after the 30 meters, this might be an obstacle to performing the 6-minute walk test. Also, one of the the catch-22s is that if you have a severely limited patient and you're walking them up and down the corridor without any monitoring, this could potentially be a problem. So, you're doing this in an unmonitored sort of scenario, maybe near the outpatient. So one has to be careful about how safe it is to perform the test on individual patients. One of the things that we often do, apart from measuring the distance in the 6-minute walk test, is also looking at saturation. So sometimes we look to see, how much does the saturation drop on exertion, and this can be a useful sort of additional piece of information. The next form of exercise assessment or exercise testing is the treadmill test, or the conventional exercise testing. It could either be a treadmill or it could be some other modality like bicycle ergometry. Once again, this is quite widely used. This is probably one of the most common forms of exercise testing that we use, freely available and not too expensive for individual units. Once again, the child's performance on the treadmill or the exercise equipment is subjective. So it depends on the motivation of the child. So that's one of the drawbacks, and children can be a little unreliable in reporting symptoms as opposed to adults. So they can be a bit unreliable in reporting symptoms, and they might not be motivated enough to complete the test. So they might give up way before they have reached the limits of their tolerance. So performing an exercise test in a young child is always a challenge, and it requires innovative, strategies and a lot of encouragement, and this has to be carried out in a child-friendly environment. So this is one of the drawbacks with the standard exercise testing. Also, the Bruce protocol involves quite high speeds, and in small children, it may not be possible for them to perform at this high speed that the belt rolls. So modified protocols are required, and then the conclusions that we draw from these modified protocols are also sometimes difficult to interpret. So in a standard exercise test, the things that you will look for when you do it in the setting of congenital heart disease are one, symptoms. One of course is fatigability, tiredness when the patient has reached the limits of their capacity. And you try and egg them on, you try and push them to do as much as they can without distressing them. Then of course you look for specific symptoms like chest pain or palpitations, depending on what condition you're trying to elicit, you're trying to do the exercise test for. Then you look at the ECG. Now, the baseline ECG in a lot of children with congenital heart disease is abnormal. So there can be bundle branch block, there can be STT abnormalities. So you should look at the baseline ECG before you start getting excited about the exercise ECG. But particularly in situations like aortic stenosis, the ECG is quite a useful tool, because what it can, if you have a child with aortic stenosis whose baseline ECG is, just shows left ventricular hypertrophy, on exercise you might have STT changes which indicate LV strain, and then this would become an indication for you to intervene, either by balloon or by surgery, whatever modality you may choose. Also, the ECG is useful if you're trying to induce arrhythmias, exercise-induced arrhythmias. So, in that fashion, the ECG during an exercise test is useful. Then you have the blood pressure response. Again, blood pressure response could either be a drop in blood pressure, which can happen in aortic stenosis. And the reason it happens is because there is a fixed obstruction. On exercise, there is peripheral vasodilatation. Now, unfortunately, because of this fixed obstruction, the heart is unable, to keep up or mount a good response to the peripheral vasodilatation. So there's a drop in blood pressure. This can be associated with dizziness or symptoms. So this is also another useful piece of information, particularly for LVOT obstruction. Sometimes you can have a very high blood pressure response. For example, in patients with, say, repaired coarctations, they have an abnormal blood pressure response to exercise. And it's important to find out, although their resting blood pressure may be near normal, they may have a very abnormal response to exercise, and that might need treatment with medications or whatever else you might want to do. But so blood pressure is the other thing. And last but not least, of course, is the saturation. Again, you want to know, how far the saturation drops. This is particularly when you have right to left shunts. Once again, the reason for saturation drop with exercise is because there is a drop in the SVR. There is an increase in the right to left shunting, and as a result, the saturation drops. So these are the various pieces of information that you would like from an exercise test. Now, one of the things with exercise testing is heart rate. Now, in an adult, or in acquired heart disease, heart rate is quite key. The peak heart rate is defined as 220 minus the age of the patient. Now, this heart rate or chronotropic response may not be mounted adequately if the patient has some sort of sinus node dysfunction. Okay, so you could have chronotropic incompetence, and this is defined as less than 80% of peak heart rate achievement. Now, chronotropic incompetence has an adverse prognostic effect. So this is also another, apart from just looking at the ECG for rhythm abnormalities and ECG changes, heart rate is also another useful indicator on the exercise test. Then, of course, you have the cardiopulmonary exercise test. Now, this is a talk in itself, to be totally honest. but I'll give you a brief gist of what it involves. Now, a cardiopulmonary exercise test is a more advanced form of exercise testing where exercise is performed and there is equipment to measure the amount of inspired and expired oxygen and CO2. So what it allows us to do is we know the amount of oxygen we are giving in the inspired gas, and we can measure the amount of oxygen that comes out in the expired gas. Similarly for CO2. Using this, we can figure out how much oxygen is being consumed by the individual. So we can calculate oxygen consumption. And oxygen consumption is dependent on the cardiac output. So if the patient has a cardiac problem, is unable to increase his cardiac output, either because he can't increase his stroke volume or because he can't increase his heart rate, then it reflects in the peak VO2 or the peak oxygen consumption. So this is one of the things that we measure during a cardiopulmonary exercise test. Then of course, like I mentioned, heart rate is important. And in patients who are unable to increase their heart rate, they have some chronotropic incompetence, for example, what they tend to do is they tend to compensate by trying to increase the stroke volume. Similarly, in patients who cannot increase their stroke volume, they try to compensate by increasing their heart rate. So if you actually look at the relationship between the heart rate and the VO2 max, or peak VO2, you see various different types of curves. So patients who have some problems with increasing the stroke volume will show a very quick increase in their heart rate, whereas patients who have a chronotropic problem will actually try and compensate for it by they cannot increase their heart rate beyond a certain level, and they will try and compensate for it by trying to increase their stroke volume if their function is normal. In some patients, they may have a problem with both the stroke volume and the heart rate, and these patients will have a flatter curve when you plot the two indices. Now, the other variable or the other measurement is what's called respiratory exchange ratio. So with any exercise test, you want to know how much effort the patient has put in. So only if you know that the patient has reached the limits of his effort, can you then say that all the results of that exercise test reflect the actual status of his cardiovascular system. So you have to ensure, you should have some way of figuring out whether this patient has exercised to his maximum ability. And that is given by this respiratory exchange ratio. So it is a ratio of VCO2 by VO2. So which is the, so carbon dioxide versus the oxygen. And normally it should be less than 0.85. Now, when the respiratory exchange ratio is greater than 1.09, it means that the patient has exercised maximally. So he's put in maximal effort. So that's a good thing. He has been able to put in maximal effort. So if he has, then all the values, if your VO2 max is then low, it reflects some cardiovascular problem. So this is a useful measure to figure out whether the patient has put in maximal effort. Then you have another index called anaerobic threshold, which is the point at which the metabolism shifts from aerobic to anaerobic, and then there's a disproportionate increase in CO2. Up till then, the oxygen consumption and CO2 production are going in a proportional fashion. Now, at one point, what happens is CO2 production suddenly becomes disproportional. And this is the ventilatory anaerobic threshold. So there are various indices that are useful to interpret what the actual problem with the patient's exercise limitation is. So this is just a table, and the 3 pluses and 4 pluses are significant. Okay. So basically, for example, if you say in patients with repaired tetralogy of Fallot, they usually have a reduced VO2 max. They usually have a reduced V by VCO2. This is V by VCO2 indicates VQ mismatch. Okay, so This table tells you what are the indices on the CPEX that are usually affected in these subgroups of patients. So if there are only 2 pluses, it means that it happens only sometimes. And if there's 1 plus, it means it happens very rarely. So 3 and 4 pluses are significant. So Fontan patients almost always have low VO2 max. They usually have low heart rate as well. Okay, so that's here, and then they often have VQ mismatch. So each subgroup of patients, you have slightly different, way that it affects the various variables of the CPEX test. Recently, the AETC, the European Pediatric Cardiac Association, has come out with a very extensive document which gives recommendations for physical activity, leisure activity, leisure sport, competitive sport, and exercise training in patients with congenital heart disease. Obviously, we have already discussed why this is required. We have cardiovascular fitness, obesity, lack of physical activity, which are huge issues for the future of these children. And also we have both practitioners and parents and patients not really knowing, what level of activity they can do. So in order to give some clarity to the situation, this document has been published, and I would recommend that you keep a copy of it, in your department, so that you can always refer to it if you have any doubt. So they have defined leisure sport. They have differentiated between leisure sport and competitive sport. So leisure sport is where you carry out physical activity, but there is no pressure to win. There is no pressure to push. Even when you're tired or when you're fatigued, there is no pressure to push beyond your limits. Whereas competitive sport, obviously, the whole idea is competition with yourself and with other individuals. So it makes that differentiation, and it gives the recommendations for both these groups of activities for all the pathologies or various subgroups of pathologies of congenital heart disease. This is again quite a useful little diagram. Now, as you all know, there are 2 types of exercise. One is dynamic exercise, which has an effect on the which is cardiovascular exercise, and then you have the static exercise, which is more like weightlifting and muscle building type activity. Obviously, any form of activity will have a component of dynamic and a component of static. But here it gives you very nicely a sort of a diagram where you have low dynamic, low static, up to high dynamic, high static. So for example, things like billiards, golf, they're low dynamic and low static. And these can be carried out quite easily by most patients with congenital heart disease. Whereas if you look at things like rowing, cycling, etc., they have a high cardiovascular component and they also have a high muscle component. So these are high dynamic and high static, and these are often contraindicated in quite a few subgroups of patients with congenital heart disease, especially when they have residual problems. So this diagram again, I think is very useful. So tennis, for example, it doesn't have much of a muscle building component, but it has a high cardiovascular component. Whereas if you look at something like weightlifting, it has a mainly muscle building component. It doesn't have a very high cardiovascular component. So it's just a neat way of classifying physical activity and sport. Now, what are the recommendations for us, any normal individual in terms of our exercise, activities, daily exercise activities? Now, the recommendation is that we have at least 60 minutes, an hour of moderate to vigorous exercise, and not more than 2 hours of sedentary activity, which means, sitting in front of the TV or computer. But how many of us actually can say this is the sort of lifestyle we lead? Not many, I'm sure. Now, This is what is recommended for a normal individual or a normal child. Now, the paper also brings out that there are certain things that can be done to promote physical activity in our patients. One is, of course, physical activity counseling. Second is to give a written prescription. Just like you give a prescription for medication, you give a prescription for the activities that the patient can do. So this allows other people looking after the patient, maybe his family doctor, maybe some nurse, other people, to also learn and know what this particular patient can and can't do. And then, of course, you need regular assessment of activity levels, either to increase activity levels, or if there has been disease progression, it might be that you have to, tell the patient to take it easy, or if there has been a lesion that has been corrected, you can then tell the patient to go back to normal activity levels. So this is a dynamic or ongoing process, and it's not a just once in a lifetime sort of thing. So these are the tables from that paper, from the task force document. So I'll just touch upon some of the lesions here. So if you look at, like we said, with healthy children, they can undergo 60 minutes a day of physical activity, okay? And this is recommended at least 2 or 3 times in a week. And they should have less than 2 hours of screen time or sedentary time in a day. So they can participate in competitive sport or leisure sport in an unrestricted fashion. Okay. Now, if you look at septal defects, under this we include ASD, VSD, PDA. Most of these, if they're large enough, will be corrected at the appropriate time nowadays. Now, once they've been corrected, they can participate like a healthy individual in all activities. There is a time that you need to give. For example, after an ASD device or a VSD device, 3 to 6 months time has to be given for endothelialization and device stabilization. Similarly, with a sternotomy, you want the sternum to be totally properly healed before you say you can do anything you want, particularly things like contact sport. But usually the recommendation is once the lesion has been corrected, pretty much a normal person's lifestyle, no restrictions. If the VSD or ASD is small, again the same advice holds good. It's hemodynamically insignificant and the patient should be treated as normal. Next we come to aortic stenosis. This can be a difficult subgroup to advise. Now, as you know, aortic stenosis can be classified depending on severity into mild, moderate, and severe, and this is based on the mean gradient. Then it can also be classified depending upon the site of obstruction. So is it valvar, is it subvalvar, is it supravalvar? There are specific problems with each of these lesions. Now, most of the recommendation that we have today for aortic stenosis is based on adult population. So this is an old, person with a calcific valve. So this is, whereas majority of our patients will have bicuspid valves. Okay, so it's a slightly different ball game, but this is all the data that we have. With subvalvar stenosis, you know that it is muscular, so there's a dynamic component. So with exercise, the obstruction actually can increase. So there's a little dynamic component to subvalvar aortic stenosis. With supravalvar aortic stenosis, you can have involvement of the coronary arteries. So these are specific issues related to the various sites of aortic stenosis. However, all we have is data from valvar aortic stenosis, and I think that is the best we have, so we have to use that. So if we have, if a patient has only mild aortic stenosis, and by that we mean a mean gradient of less than 30, they can be treated as a healthy individual, okay, both in terms of cardiovascular and musculoskeletal exercise. Now, the issue is that this has to be reassessed. So this has to be assessed at regular intervals. For example, if the valvar stenosis then progresses to become moderate or severe, then your advice might change. So it's important to change or to give advice regarding physical activity depending on the changing hemodynamics. Now, if there is moderate aortic stenosis, which is a mean gradient, say between 30 and 45, you will limit your activity. So there will be some limitation to moderate intensity only of competitive sport. Okay, this is not leisure activity. I'm talking about competitive sport. You'll have to limit the intensity to moderate intensity. So you're not going to be doing high intensity activities. You're doing moderate intensity activities. One of the issues with lesions like aortic stenosis and competitive sport is that when a young person gets involved in sport, for example, they're doing it at a sort of competitive level, they want to be professional athletes, it becomes difficult if you expect the lesion to progress. So if you tell them that yes, you can go ahead and participate in competitive sports, and they get very involved in it and it becomes a huge part of their life, then at a later point to tell them, look, you have to stop now, is going to really break that child's heart, and the child is not going to be willing to do it. So you have to be a little bit careful even at the outset, especially perhaps in a lesion like moderate AS. You have to give advice accordingly, because there might be, of course, moderate AS can be treated. You know, if it becomes severe, you can treat it, you can balloon it or operate on it, and then maybe after the intervention, the child can go back to the previous level of activity. But there will be a period of 1 or 2 years, or whatever, at least a year, when they're recovering, when they have severe AS, and you're waiting for surgery. When they've had the surgery, then they recover from surgery. At least a year when they can't be in training. So if they're considering a professional career in sport, then this might be a problem. So you have to be slightly careful about advising these patients. Aortic stenosis, like we mentioned before, exercise testing is a fantastic tool. And once again, just to remind you, the things we are looking for are symptoms. We are looking for a fall in blood pressure and ECG changes, STT changes on the ECG. So these are the 3 things that we look for with aortic stenosis. If there is severe aortic stenosis, really the patient needs to be treated. So you will treat the aortic valve problem, and then they can then go back to perhaps a normal level of activity. Aortic regurgitation, usually there is not much restriction when the AR is only mild to moderate. If the AR is severe and there is significant left ventricular dilatation, then you will have to lay down some restrictions, and probably they can carry out only moderate activity. If there's ventricular dysfunction, then that advice would become more stringent, and they can carry out low to moderate intensity activities. Then we go on to the subject of the bicuspid aortic valve. Bicuspid aortic valve, I think the main difference is the fact that this is often associated with arteriopathies. So this could be associated with aortic root enlargement. Now, aortic root enlargement can be quite a serious issue. If it is only mild, then you can treat them as normal, and they can probably carry out full level of cardiovascular activities. You will, however, limit the musculoskeletal, which is a static exercise like weightlifting, etc. You will limit that to moderate intensity. So if there is only mild dilatation, then this is possible. If there is more than mild dilatation, then you will have to limit both cardiovascular and musculoskeletal activity to moderate intensity. If there is severe dilatation, you should operate or rectify the problem before you allow the patient to perform any competitive exercise. So I think aortic root dilatation is important. Coarctation of the aorta, once again, the key thing is there are a couple of key things. One is we have to rule out, especially when you look at patients who are followed up after coarctation repair. Obviously, if you find a coarctation, you have to deal with it. If it's in a neonate, surgery. If it's in an older child or adolescent, stenting. So once this has been dealt with, during follow-up, then you have to assess whether there is any residual obstruction or whether there is any aneurysm formation. So these are the 2 main things. If you have neither of these in a significant way, then the next thing to assess is the blood pressure response. So an abnormally high blood pressure response is when the BP is greater than 3 times the standard deviation. So you need to have normal charts for that particular age, body surface area, and figure out whether the peak BP response is over 3 times standard deviation. So the exercise test is useful in this setting. Cardiovascular activities in a patient who has a normal blood pressure response is as normal. So they are allowed the full spectrum of cardiovascular exercise. Musculoskeletal, once again, you limit to moderate. So most aortic problems, you have to limit the musculoskeletal activity to low to moderate intensity. Then we have pulmonary stenosis. If the gradient is only minor, mild, less than 30, they can be normal. There is absolutely no restriction. If the gradient is more than mild, say moderate, and you're not ballooning the valve, you're sitting on it, then in terms of competitive sport, you have to limit them to low to moderate intensity competitive sport. So usually outflow tract lesions of both ventricles, there is if there is moderate stenosis, then you would have to limit their activity, especially competitive activity, to low or moderate. Then you have tetralogy, post-repair, it depends on lots of factors. It depends on whether they have pulmonary regurgitation. It depends on whether they have right ventricular dysfunction. So if it's a perfect tetralogy repair, wonderful hemodynamics, not much PR, everything looking good, no RVOT obstruction, then these are like healthy people. So they can then participate in full range of activity. You may want to do an exercise test, and this is just to rule out arrhythmias. But as you probably already know, usually arrhythmias and tetralogy are related to hemodynamic issues. So if you have no hemodynamic issues, it is unlikely that you will have arrhythmia issues. So tetralogy without significant hemodynamic issues should be treated as normal. Now, if a patient with tetralogy has significant pulmonary regurgitation, but has normal RV function, then they can participate in moderate intensity activity. Whereas if the patient has got RV dysfunction, then they are limited to low to moderate intensity activity. So this is both cardiovascular and musculoskeletal. So in this fashion, there are recommendations for each of these subgroups of patients. TGA is the other thing, which is important, and this subgroup is important because they specifically have coronary artery abnormalities. So in these patients after arterial switch, even if they have a good repair, in terms of competitive sport, you will not allow them to perform more than moderate because there is an incidence of coronary artery problems in these patients. Again, you will routinely put them on the exercise, treadmill. Every few years, you will do an exercise test just to make sure that they are not developing coronary artery disease. If the exercise test is abnormal, has changed, then you will probably do a cath on them and do coronary angiography to look at the lesions. Then you have patients with a systemic right ventricle, like congenitally corrected transposition of great arteries. These patients as well, the advice should be individualized. So if they have RV dysfunction, if they have AV valve regurgitation, then you should limit them to low intensity activities. There is also, if they engage in high intensity activities, there is a fear that the AV valve regurg could worsen. So even if they have a good ventricle and no AV valve regurg, they are limited to moderate intensity activities. Then again, you have the Fontan patients, only low to moderate intensity competitive sport. So, you have to be careful, or, you have to individualize the advice you give to your various patients depending on their anatomy. So in the real life scenario, there are not many of our patients who are undertaking competitive sport. So I think, these recommendations are sort of the extreme of the spectrum. So if you look at most of these activities, say low intensity activities include things like golf, billiards, etc. at a competitive level. So I would say a Fontan patient, day-to-day activities, non-competitive activities, they should be able to walk. They should be limited by themselves, by their own symptoms. They should be able to walk, as a form of exercise. They can do gentle cycling, probably not uphill cycling, but cycling on the flat. They may be able to swim, but maybe not overdo it. So these are probably activities that a patient who's had a Fontan, who's doing well after a Fontan, can undertake easily. So it has to be tailored to the patient's condition. Eisenmenger's or pulmonary hypertensive patients are a separate subgroup. Now, these patients on exercise can get very cyanotic. So their level of intensity of exercise should be limited to low intensity, and they preferably should not undertake too much of static exercise or musculoskeletal exercise. Having said that, secondary pulmonary hypertension is better than primary pulmonary hypertension, because in primary pulmonary hypertension there is a risk of syncope. Whereas in secondary pulmonary hypertension, because you have a shunt somewhere, actually these patients can exercise much better than patients with idiopathic pulmonary hypertension. So the advice is slightly different. So this advice is only for patients with secondary pulmonary hypertension. Recently, there's been a study that's been published where they have actually exercise trained patients with pulmonary hypertension, and they have found that overall their exercise capacity has improved. Now, exercise training as a way of improving the functional exercise capacity of patients with congenital heart disease has been carried out by several groups of authors, and they have come up with quite promising results. So if patients undergo a training program where they have to perform a certain level of exercise, they have found that at the end of that training program, the CPEX indicators have improved. VO2 max has improved, and we know that VO2 has a direct relation to mortality. So whether this translates into mortality, survival improvement, we don't have that data yet. But it is encouraging that at least in some subgroups of patients or in some studies, there is an improvement in the VO2 max. So this is what I was talking about. So these are various papers. You can see the numbers are quite small. And some of them are extremely variable pathologies, which makes it a little difficult to interpret. But if you look at, say, perhaps the Fontan subgroup paper, they found that there's been an increase in the peak VO2. Again, a couple of other studies have also shown that increase, but once again, small numbers. But overall, I think this is encouraging, and really there has to be, these patients with congenital heart disease do need cardiac rehabilitation. Right. So I'm just briefly going to touch on the arrhythmias, because now we have sort of done the structural heart problems. This is another paper, once again by the European Society of Cardiology, and this is actually an overall recommendation, adults and children, which gives you exercise recommendations for patients with arrhythmia. So starting from ventricular ectopics onwards up to ventricular fibrillation and the various channelopathies, this document gives you advice as to what level of exercise they can perform, whether they can perform exercise at all, etc. So if you look at ventricular ectopics, this is a common problem that we come across, and often it is difficult to know whether this is benign or anything malignant. So with ventricular ectopics, the general recommendation is, if they are not very frequent, and by that you mean less than 2,000 ventricular ectopics per 24 hours, so you have to do a Holter in order to find this out. If they are monomorphic, if on exercise they don't increase and the symptoms don't increase, this is believed to be benign. Okay, and these patients should be treated as normal. They should be exercised, they should be followed up, but there needs to be no restriction in their activity. If the ectopics are more frequent, and if they're, if they are not, they are polymorphic, and there is some increase in the ectopy on exercise, then something called deconditioning is done, where the patient is taken off all sport and assessed. And then once after that deconditioning, if the ectopics have disappeared, then you can reallow sport. So there is that subgroup. But if there is an underlying problem, for example, you have long QT syndrome and you have ectopy, then no competitive sport and only light, moderate intensity leisure time sports. So it depends very much on the how the ectopy, how much of ectopy is there, whether there's an underlying reason or structure, either structural problem or an electrical problem with the heart. What happens to the ectopy with exercise? These are all various factors to consider before giving activity advice. Then we go on to ventricular tachycardia. Now, ventricular tachycardia needs to be assessed carefully. So a series of investigations need to be performed. One, of course, is echocardiography to look for gross abnormalities. This can be quite difficult to pick up. It might be a structurally normal heart. The other imaging modality which is increasingly being used is the MRI. So this can pick up conditions like arrhythmogenic right ventricle, so ARVC. So this condition can be picked up by MRI. Then the baseline ECG. So you want to look at the ECG to see if there are any baseline ECG abnormalities. ARVC has specific baseline tachycardia. That can also help you. Say RVOT tachycardia. This is basically an ectopic focus in the right ventricular outflow tract. This is a benign tachycardia. It is monomorphic. It presents in tachycardia with left bundle branch block and an inferior axis. So these features give you a clue that this is indeed RVOT tachycardia. This can be ablated. Of course, there is a small risk of perforation and so on, but it can be induced on the table and ablated. But these patients generally can exercise. Even if they had the RVOT tachycardia, they can exercise, and it's not a malignant type of tachycardia. However, say for example, if you have channelopathies like long QT syndrome, and that again is something that you can pick up. The QT interval is important. The STT segment is important because they have specific morphological characteristics. So the ECG is very useful in assessing a patient with ventricular tachycardia. Then, of course, exercise testing. This is particularly useful in exercise-induced VT. Catechol and aminergic VT is called. And basically, you exercise the patient and the patient goes into VT. And these patients, again, they need to be restricted in terms of what they can do. They are not allowed to do competitive sports. Similarly, patients with long QT syndrome are not allowed to do competitive sport. Finally, you can do an EP study. Like I said, particularly for things like RVOT tachycardia, it's very useful because you can do an EP study, and then if possible, you can ablate the focus. So then proceeding on from VT, we go to VFib. If VFib is because of a correctable cause, for example, a drug overdosage or something like that, then once that condition has passed, the patient can go back to normal. But if it isn't, and this is an intrinsic cardiac problem, then the patient probably needs an AICD. Once the patient has an AICD, there are certain restrictions related to the AICD, like avoidance of contact sports, avoiding sports that involve moving your arm too much because you might dislodge the lead. So all these various restrictions might come in because of ICD implantation. But this is how you treat patients with VFib. Again, like I said, channelopathies, usually they are prohibited from competitive sports, and they can only do sort of light to moderate intensity leisure sports. There are specific trigger factors for long QT syndrome. One of them is diving, because swimming and diving can induce tachycardia in a certain subgroup of long QT. Similarly, acoustic stimuli, auditory stimuli can stimulate in long QT type 2. So these are specific stimuli to avoid. So you have to be careful. Say, for example, if you are into shooting, rifles, it's actually a very low intensity activity. But in a patient with long QT syndrome, which is stimulated by auditory stimuli, it might not be such a good idea. So this paper gives us recommendations for patients with arrhythmias and electrical problems. Once again, with ARVC, you cannot have competitive sports. So a lot of these ventricular tachyarrhythmias don't really allow, except for the benign forms, for example, RVOT, VT, they don't really allow for competitive sport activity. This is slightly different from the structural problems. Structural problems, the milder forms, they behave like normal, healthy individuals. Here, even if you have carriers or people, a person with just long QT syndrome, they can't do competitive sport. So implantable defibrillators we already touched upon. Once again, they can't do competitive sport. Contact sport should be avoided. And sports which involve, like, say, a very high level tennis or racket sport, which involves moving your arm excessively, that can lead to crush of the lead or dislodgement, and these can be issues. So this is a sort of an overview of patients with arrhythmias and what sort of exercise they can do. The other point I forgot to mention was in patients with spontan circulation or other patients who are on warfarin, again contact sports should be cannot be undertaken, should be prohibited. Okay, so I mean that sort of brings me to the end of my exercise talk. I'm happy to interact with you. It's been slightly didactic. I apologize for that, but I think it's the nature of the subject. So if you have any questions now for me, I'm happy to take them. Was that useful? Do you have any, anything you want to ask me?